upslope, and then chin hold, upslope, and then cradle hold, downslope. And so those are really the primary ones. All right, good. So for all of these techniques, the patient needs to be all the way back to you. So you guys can go ahead and roll the camera. So patient's all the way back to you. And I mean that the patient's head should be right on the ear integrate spot, right on the edge of the table, so that when you're standing there, your body is as close to the patient as possible to maximize your mechanical advantage. So patient's all the way back to you. The pillow is not under the shoulders. All right, we don't want any cervical extension. So bring the pillow away from the shoulder, okay? You're gonna come up to the patient. The table should be at mid-thigh or proximal thigh, but not waist, not for cradle hold. Cradle hold is about mid or proximal thigh. When we go to chin hold, we realize the table needs to come up. But for cradle hold, we have the advantage of having a lower table, which is why mechanically it might be an advantageous technique in most cases, because the lower the patient is, the better force you can get into the patient. So for cradle hold, mid-thigh, maybe proximal thigh. You're going to approach the patient. If your right hand is going to be your thrusting hand, or I prefer contact hand, you're going to bring that hand here onto the side of the neck. I'm sorry, my hands are cold, Jess. All right. Onto the side of the neck. The thumb is always going to be on the mandible. And the reason is simple. You don't want to go over the carotid artery if you can avoid that. It's not very comfortable for the patient. And you want to have a purchase on the skull so that at the end of the technique, you can do a little bit of rotation with that thumb. And so the thumb never leaves the mandible. Thus, a different part of the anterior lateral aspect of your index finger is going to contact the posterior articular pillar. If it's lower in the neck that you're shooting for, it's going to be further down your finger, and that's fine. The amount of pressure with your index finger on the level is not very important. It's really only there to guide the movement. It's not there to create much movement. Most of the force is generated with the upside hand. And so again, your thumb is going to be on the mandible, and your index finger is going to be on the articular pillar. On the opposite side, your hand is going to be well up and above the ear. You want it higher to maximize the torque arm, the lever arm, that you have from the target motion segment to the point of contact. So you want that quite high up and above the ear. Your fingers are pointing sort of in between, straight down, and medial. They're right in between that, so that that hand is able to generate either rotation or lateral flexion as seen fit. Whatever contact hand you're using, that foot is back. So we call that your thrusting foot, and it's always in a diagonal stance facing the far side corner of the table. That is your setup. Your contact humerus is adducted, and your wrist is always in neutral. You don't want the arm to come out, and you don't want the wrist to be extended. You are generating a lot of this force from your body, and in order that to get into Jess, it needs to go through my arm. Don't create an angle the force needs to wrap around, because you're going to lose a lot of it. And so you want to have a straight wrist. So your setup is going to be there, mandible, articular pillar, straight wrist, adducted, thrusting foot back, patient close to you, proximal thigh. That's your setup, diagonal stance. All right, explore the rotation. And remember, this is for upslope technique, primary leverage rotation. Explore the rotation and realize you don't want to be anywhere near that point. That's her end range. That's not where we thrust. We thrust in mid-range using combined levers. Come back, add a little bit of lateral bending, and explore flexion. If you feel like, you know what, there's just still too much movement in this system, bring her back, add a little bit of side shift, then add lateral flexion, then explore rotation. Usually at that point, you're reasonably happy with the crispness in a reasonable mid-range position. From there, the thrust is primarily with the upside hand into rotation, being guided by the contact hand. Good. So in real time, approaching the patient, diagonal stance, exploring that rotation, coming off of that, little bit of side shift to it, little bit of lateral flexion, re-exploring that rotation, and then thrusting into rotation. Good. You can keep rolling, or you can do separate ones, whatever works for you guys.